So welcome listeners to the Coriel Ortho podcast with me, Tony Wilkinson, consultant podiatric surgeon, foot surgery expert and founding director of Coriel Orthopedic Group. Now this is a podcast where we delve into everything surgical, medical and healthcare related. And today I'm joined by my friend and colleague Scott MacInnes, who is a consultant orthopedic surgeon specialising in shoulder surgery. So today we really want to delve into an area that's really out of my comfort zone, into the upper limb. And we maybe touch a little bit on elbows as well, but the predominant area is shoulders. So welcome, Scott.
Thanks for having me.
So shoulders then. So out of all orthopedics, and I've spoken to some of my other colleagues in the lower limb, I mean, we really hear about, big joint replacements and huge numbers and kind of shoulders. I do think to myself, well, is there a lot of surgery to do in the shoulder? Because, I never really see patients coming to my clinic saying I've had a shoulder replacement or I've had this done, but huge amount of saying they've had hip and knee surgery. So what really got you into shoulders, with it being one single joint really in all of orthopedics?
Well, because shoulder's the best joint in the body, isn't it?
Fair enough.
I think the main thing that interested me was the fact that the shoulder's a really complex joint. It's not actually one joint; it's four joints in total.
Okay.
And because of its complexity, it really interested me. And you're really going to have to think about it in terms of coming to diagnosis. But the advantage of that also is it gives you a huge spectrum of different procedures and conditions. So my practice involves arthroscopic surgery, so keyhole surgery, all the way through to joint replacement, big open complex surgery. Yeah. So there's a wide variety of procedures that you can do. And the other thing is that shoulder surgery is a relatively new subspecialty, so it really only took off properly in the 90s.
Okay.
And as a result of that, it's a very fast-moving subspecialty, and there are new advances all the time, new techniques coming out all the time. So it's an exciting subspecialty, certainly. And the other advantage is that there's huge potential for research as well because of these advances. Yeah.
Okay. So obviously you did a lot of other types of orthopedics. So in terms of shoulder surgery, was it because it's kind of moved from open surgery to arthroscopic, and everything seems to be moving in this keyhole type direction? Do you feel like you're missing out on open surgery now, or do you still feel like you do a lot of that around the shoulder anyway?
Well, no, so I still do a lot of open surgery as well. So all the shoulder replacements, for example, that I do are open.
Okay.
A lot of the trauma that I do, all the complex upper limb trauma that I do is open. But a lot of the sports medicine or the soft tissue work, and much of that is now arthroscopic.
Right, okay. So was shoulder surgery done badly before, do you think, when people were generalists? Were they, because obviously, I mean, people did have skills in arthroscopic, but I can imagine that there's one thing putting a camera into a joint, just have a look around and see if there's anything going on, and another thing operating with a camera. That seems like quite a significant jump up in skill level.
Yeah, I mean, your generalists used to either do a hip replacement, a knee replacement, your bunions, and some spinal surgery.
There's nothing wrong with bunions, though.
No, but that's, I mean, the shoulder was sort of forgotten about, really. It's an upper limb fracture, we'll just leave it, it'll be fine.
Right.
But actually, if you think about how important your shoulder is, so when I see my patients day to day, their shoulder function is hugely important for their daily life.
Yeah.
So patients who've got severe pain and dysfunction in the shoulder struggle with getting dressed, brushing the hair, sometimes even using cutlery.
All those simple things that you take for granted. Really.
Yeah, so we often get told, it's not a weight bearing, it's not a weight bearing joint like a hip or a knee, but it's a load bearing joint, the shoulder, and it's really important. And actually, when patients end up pain-free after treatment, it can be life-changing. So shoulder replacement, for example, can be a life-changing operation for patients.
Yeah. So I mean, the shoulder compared to other types of joints is quite an unstable joint, really, isn't it? I mean, it's relatively easy to dislocate your shoulder, whereas it's much more difficult to dislocate your ankle or your knee or your hip, which is that. What is it about the shoulder that makes it unstable? Because obviously you've got the deltoid muscles and large muscles invested into it, but why is it so unstable?
Yeah, so you've got a relatively small flat socket with a big large ball. Right. So it's a bit like a golf ball and a golf tee.
Of the joint,
yeah, so it's a golf ball and a golf tee. Right. And it doesn't take much to push that golf ball off the golf tee, does it really?
Right.
So it relies on a number of stabilizers. You've got what we call static and dynamic stabilizers. So your static stabilizers are the sort of congruity of the bones, which unlike the hip, you don't have that same congruity in the shoulder, where you've got a ball that sits inside a socket.
Yeah.
Your other static stabilizers, around your socket, there's a a tissue called the labrum, which deepens and widens the socket. It's a bit like, I explain it to the patients, like having, the sort of bowling buddies in the bowling alley. It stops the ball from dropping into the gutter.
Right.
So the labrum works a little bit like that. But on top of that, you also have your dynamic stabilizers, so your rotator cuff muscles. So if you have a little look at my model here, you can see that that's your main ball and socket joint in here.
Yeah.
That's the humerus, which is the upper arm bone, and that's the humeral head, which forms the ball of the ball and socket joint.
Yeah.
And then your shoulder blade, which is this large triangular shaped bone, has the glenoid on it. So the glenoid is the socket. And these muscles that surround it, so these 4 muscles are called the rotator cuff muscles.
Right,
Okay?
so it's all of the muscles as a rotator cuff.
So so there are 4 muscles in total. So this is subscapularis, that's supraspinatus, infraspinatus, and teres minor at the back there. And these individually will rotate your arm and your shoulder in different directions. However, they actually come together and form one continuous cuff of tissue, tendon tissue.
So it's joined, each muscle is joined by kind of a fascial layer between it.
Yeah, but they all come together to form your cuff. Hence the reason it's called the rotator cuff.
Okay.
So individually they work in terms of movements of the shoulder, but actually their main job collectively as a team of 4 is to pull that ball onto the socket.
Right. Okay.
So they work by holding the humeral head onto the glenoid and improving stability. So the position of your shoulder blade and the function of your rotator cuff muscles can be just as important as your static stabilizers for the stability of the joint. The shoulder blade, I think a lot of people forget about the shoulder blade in terms of its movements and its position with regards to instability. In that, I would say actually that when I was training, some of the physios that I worked with actually taught me just as much about the shoulder and the shoulder function as the surgeons did. And if you think about the shoulder blade as a sort of C line balancing the ball on its nose, if your C line is well planted on all 4 flippers, then it finds it quite easy to balance that ball on its nose. But if that C line is on one flipper, then it's going to really struggle to hold that ball, and it's going to drop off the nose.
Muscular instability.
Yeah, so your shoulder blade is vitally important for the stability as well as the ball and socket joint itself.
So I remember you did see my sister with a winged scapula, as you call it. So that's kind of the instability of the shoulder blade, is it, where the muscles are imbalanced? Because I know you said the treatment was physiotherapy.
Yeah, so there's lots of different reasons for it, and you could have a whole podcast on winging scapula. But essentially, I see lots of patients with what we call scapular dyskinesis, which essentially means abnormal movement of the scapula. And a lot of scapular dyskinesis, depending on the cause, can be treated with physiotherapy because it has a knock-on effect to the rest of the shoulder. So again, this is not just your sort of standard ball and socket joint. Everything has a knock-on effect. So I see patients who come and see me who've got neck pain or pain in the middle of the back, and sometimes it's because of the shoulder. So if you've got a very stiff, painful glenohumeral joint, ball and socket joint, then you rely on your shoulder blade for movement. So therefore, a lot of patients come with pain around the shoulder blade. But the problem's not predominantly with the shoulder blade. The problem is actually in the ball and socket joint.
So if some people do certain exercises that strengthen one part of the shoulder to another, they can upset that and cause a problem. I know sometimes bodybuilders, you always seem a bit hunched forward, don't they? Because they've done a lot of bench pressing and a lot of heavy weights in certain areas. Perhaps neglect flexibility a little bit. I think most people neglect flexibility. So they end up being hunched in one place. Are they more prone to getting sort of injury then with the shoulder? Yeah,
so hence the reason that we have many sports that have sports persons who have shoulder problems. Because muscle imbalance can have quite a profound effect on your shoulder function. So your classic is your sort of young men that go to the gym with their mates and they hammer the bench press. So they do what we call the mirror muscles. And they forget about the muscles in the back. So what that does is if you tighten up your pecs, particularly your pec minor muscle, it pulls your shoulder blades forward, and then you see them all like this next to the Smith machine in the gym. And that's a really bad position for your shoulder blades to sit in. That's called protraction of the shoulder blade, because what it does is it closes off this little space in here where your rotator cuff tendons travel. So you're more likely to have problems such as impingement. So years ago, sort of 10 years ago, we'd have patients on operating lists where they'd have decompressions, which is where we make that space wider by shaving away some bone,
Right.
including some space for the tendon.
Okay.
But actually, our understanding more of the impingement of the rotator cuff tendons actually comes more back to this dynamic issue where your shoulder blade position is really important. So if you can address that first, and actually address the rotator cuff dysfunction,
Right.
then you can often get away without surgery.
Yeah.
Not
Okay.
always, but often you can.
So you all hear these fancy terms being thrown around, so frozen shoulder, slap tear, other terms like that. What sort of layman's terms are there? What do they actually mean? How do you tell the difference between one thing and another from a patient point of view?
Well, they're all sort of distinct conditions and problems within the shoulder. So it depends on which one you want to know about. But so when I have medical students in my clinic, we sort of play a game really, because you can pretty much diagnose a patient from their age usually. So and I'd say the medical students get it right about 80% of the time, just purely from what do you think this patient's got from their age.
Right. Okay.
So
why is that? Why does age make a difference? Is it because it's just the area of the muscles weakened, or is it what's age got to do with the actual injury or tear?
It's mainly because different shoulder problems appear at different points in your life, whether it's due to wear and tear, whether it's due to playing a lot of sport, that sort of thing. So if we see a young patient come into clinic, then usually it's instability. Or a problem with their shoulder blade function, which can potentially then also lead to instability or pain. If it's a middle-aged patient and the medical students' idea of what middle-aged is when they're 20 compared to what my idea of middle-aged is very different. If it's a middle-aged patient, then it's usually either a frozen shoulder or it's a cuff problem, such as a subacromial impingement, which is where that tendon here gets pinched underneath this point of your shoulder. This is the part of the scapula, the shoulder blade, called the acromion, which means the highest point in the shoulder, and that causes inflammation of the rotator cuff, one of the rotator cuff tendons, and pain. And sometimes actually you can develop a tear in the tendon as well. So that's what we generally tend to see in middle age. And then elderly patients either have a torn rotator cuff or arthritis within the ball and socket joint. So common things are common, aren't they?
Yeah. Okay, so if somebody has a frozen shoulder, then what does that feel like to a patient? Is it just they can't lift their arm up in certain? Is it on the sideways or is it in the front? What does it do?
A frozen shoulder is actually a miserable condition.
Yeah.
It's a really painful condition, and probably the one thing that causes patients with frozen shoulders to come in and see me is the fact that they can't sleep at night.
Right. Or so lying on it.
Or they can't their pain when they're lying down is too bad and it keeps them awake at night.
Okay.
Or often they're dragged in by their other half saying, "Can you please sort them out because they're keeping me awake as well." So with a frozen shoulder, we still don't truly understand why it happens. There are some associations for frozen shoulder, but the vast majority, so about 2/3 of all frozen shoulders that we see, we never really know why it's happened. There are some theories as to whether it's a genetic predisposition to it, or whether there's a sort of autoimmune condition going on that causes inflammation within the shoulder. We do know that it's associated with diabetics. In fact, recently we've just done a study looking at pre-diabetes, because we all know about the association of diabetes and frozen shoulder and have done for many, many years. But actually, the pre-diabetics are really important patients that we need to be picking up, because they're the ones that you can reverse their pre-diabetes before you become diabetic. And what we found was actually that the pre-diabetics had frozen shoulders as bad as the diabetics. And we were picking them up, we're screening them in our clinic, and we're picking them up. So there's a known association for a long time with diabetes and also thyroid disease as well. And we think it's because patients with those conditions have a sort of underlying low-grade sort of inflammation within the body. Okay. So essentially what a frozen shoulder is, it's inflammation of the lining of the joint, the capsule. Right. It's what we call capsulitis. Yeah. So the condition, the medical term for frozen shoulder is adhesive capsulitis. Right. Adhesive meaning it becomes very stiff, and capsulitis meaning that you get inflammation of the capsule. Yeah. And there's 3 stages to a frozen shoulder. So your first stage is what we call the inflammatory stage. So that's when patients think, my shoulder's starting to feel a bit sore. It's not really bad, and I've still got my range of motion, but it's starting to hurt a little bit. And as the days and weeks go on, it gets sort of progressively worse. And then what happens is that they then drop into what we call the frozen stage.
Right.
So that inflammation causes thickening and scarring of the capsule. And like any scar tissue in our body, like if you think of burns victims, becomes contracted. So it has little cells on it that causes contraction.
Yeah.
And suddenly the patients think, not only is my shoulder painful, it's now I'm starting to lose my range as well, or I can't get my hand to the back of my head anymore, I can't brush my hair, or I can't get my hand round my back when I'm at the loo, or when I'm trying to pull my trousers up, or some people use it as an excuse to not to put their hand in the back pocket, you know. So they start to lose their range of motion, and that's called the frozen stage.
Right.
And then your third stage is what we call the thawing stage. So if you left it alone and did nothing with it, the vast majority of people with frozen shoulder would probably eventually get better on their own.
That's just because the inflammation's calming down.
Exactly. So the inflammation then eventually settles down, and they, as they use it more because the pain's better, they stretch out that scar tissue over a long period of time. And the problem is that whole process can take sometimes up to about 2 years.
Yeah.
So the treatments that we have for frozen shoulder are to drastically reduce down that
so it's speeding up the recovery time. So is that sort of, if it's inflammatory, you would think that steroid injection will be a go-to for that? Is that something that you use? Do you need to do that under ultrasound, or do you use it
potentially, but it depends on where you are.
Yeah.
So the vast majority of patients that come to see me are beyond the inflammatory stage, because they only come to see me when it gets really bad. Because a lot of people think, oh, you know what, it'll get better, won't it? It'll be fine. But actually, when it starts to get worse, and they think, hang on a second, I'm losing my movement in my shoulder, I'm going to have to go and see somebody. They then come and see somebody like me. So I would say probably 90% of people that I see with frozen shoulder are in the frozen stage.
Yeah.
And the problem with that is that you can give them a steroid injection at that stage, and it will likely make their pain better.
Yeah.
And they may get a slight improvement in the range of motion as well. But the problem is, if you've got a lot of scar tissue that's developed, you may not see a drastic improvement in your range of motion, and you're still going to require months of physiotherapy in order to stretch out that scar tissue and get your range back. So there's sort of two other kind of mainstay treatments at that stage for frozen shoulder, and they both work well. One is a type of injection called hydrodistension or hydrodilatation.
Okay.
And it's a bit, I explain it to patients a bit like a sort of supercharged injection. And
is this like prolol therapy?
Well, no. So hydrodilatation.
It's just fluid going.
So it's done under X-ray guidance.
Right.
The needle goes in. We inject some local anaesthetic and some steroid in, and then we inject in some sterile water, which essentially blows up the capsule like a water balloon.
So it's expanding
and stretches out the capsule. And often, if the pressure gets high enough, it will tear the capsule. Now, because we've put some local anaesthetic in and the shoulder's numb, the patient doesn't feel its pain usually, but they often feel a pop in the shoulder, and it can actually give you an almost instant improvement in your range of motion.
Right. Okay.
And that works quite a bit of the time. And I would say actually the number of patients I have to operate on now has reduced as a result of that treatment. We have patients who don't respond to that, and they come back a number of weeks later and say, look, it hasn't really, my pain's a little bit better, but I'm still sore, I still can't sleep at night, and my range is still poor. I want something doing because I can't do my job or whatever. And they're the ones that would then talk about surgery, where essentially you put a camera into so keyhole surgery, put a camera into the shoulder, and I release the scar tissue with a little radio frequency wand, which is a little 4 millimeter
you burn it out.
Yeah, you basically divide the scar tissue and take it out, and it's a pretty quick procedure. It takes about sort of half an hour to do, if that. And it's one of the few procedures that I do that gives you an almost instant improvement in your range of motion. And so often when we examine the shoulder with a patient asleep on the operating table, they're very restricted in their movements. And then half an hour later, they've got full range of motion.
What sort of recovery is it for? So are they the sort of patients that you just mobilise straight away? Because I know most people have an operation of the shoulder, they come out in a sling and they can't move the shoulder for so long, but obviously you want that to move straight away. So what do you do with them?
So patients will also often have a sling on when they come out of surgery because they'll have a block in the shoulder, depending on the
that's just for the anaesthetic.
Yeah, so they'll often have the nerves in the neck blocked so that their arm is completely numb, and that's good for pain relief afterwards. It's also good because I can go and show the patients immediately after the operation. Look at that range that you've got now that you never had before, and often they're like, wow, I haven't had my hand up there for a long time. So, and that's good for the patient's recovery because it's important for them to know that I can get moving this. Because if they stay in a sling for 6 weeks after, when they come and see me 6 weeks later, they'll be stiff again because the body's just going to scar up like it did before. So we're really careful with telling patients that from day one, you have to just get going. And the patients who do the best are the ones that just get moving. And they'll often come back at 6 weeks and say, that's completely changed my life. Right. I can sleep at night, my pain's better. They'll still have some discomfort at that stage because they've had surgery and things are still healing and settling. And they don't quite get the full range at that early stage as I got on the operating table, because it's a sort of race between patients maintaining that range and it scarring up again. And there'll be a little bit of scarring up. So, but over time, they will regain that range.
Yeah, it can always be a little bit disappointing, can't it, sometimes, when you've got some range of motion on an operating table and then down the line, because once they walk out of your theatre, you're not got any more control, and you'll get some patients who will be, I'm going to really do as I'm told and really work this, and others will just, I'm too scared, I don't want to do anything, and then it's just gonna not really work out quite as much. So if I came to you with a frozen shoulder at that frozen stage, what you're likely to say to me in terms of treatment pathway? You're going to refer me to for physiotherapy, or have they come from the physio? Because it kind of seems logical to me that if I had a frozen shoulder and I hadn't tried anything, then physio would be my go-to rather than you, because I'm likely to need physio. Or do I need to come to you for the diagnosis first to get that confirmed? Or what's the likely go-to?
So a lot of patients will come from physio.
Okay.
Because they've been seen by the GP and sent to the physios, and they'll have tried to do physio and it's too painful and they can't do it.
Right.
So then they get sent to me because they're not progressing.
Yeah.
And in fact, there is some evidence that if you do too much physio within the very early stage, in the inflammatory stage, then you can sort of accelerate that process and make things worse, so because it becomes more inflamed.
So it's balancing the rest really with the mobilisation, I suppose.
But the important thing is that once you've had treatment from me, physio is absolutely the single most important thing for you, because you've got to get moving afterwards.
Yeah.
So when you asked me about why did I choose shoulder surgery, one of the other advantages of shoulder surgery is I get to work with lots of other sort of allied health professionals. So physiotherapy is really important for my patients.
Yeah.
So I enjoy working with the physios because we learn from each other, don't we?
Yeah.
So physio it can be an issue in the very early stages, but it's really important after any treatment. But really, once they've been referred to me, we're looking at either hydrodilatation, or if you're lucky and you get it early enough, then an injection might be enough to sort of nip it in the bud, really. What I do say to patients is that because you've had it on one shoulder, you are more likely to have it in the other shoulder.
Right.
But they start panicking. Oh no, I don't want this again. But actually, you say, what I generally tend to say to them is that, look, be reassured that if the other one starts feeling sore, come and see me early, and if we give you an injection in the early stages, we can often nip it in the bud before it gets to the stage where you're at now.
Is it a sort of injection that you would do, or do you need ultrasound guidance, or would you send it to a radiologist?
You don't have to do ultrasound guidance. You can just do it in the clinic.
Right, okay.
Steroid injection.
Because a lot of GPs and things do injections like that. I always think, are they just pushing it in somewhere, hoping for the best? When I do a lot of injections, I tend to now use ultrasound just to guide me if I'm doing small joints. And the great thing about ultrasound in clinic is you can physically show the patient the anatomy as well, so it does help with the patient's understanding of it. But ultrasound guided injections have revolutionised my practice. I mean, I can't imagine working without ultrasound. But are you still favouring anatomical sites and injections rather than ultrasound? Is ultrasound something you do yourself?
It depends on what you're treating.
Right.
So for something like a frozen shoulder where you want to inject into the ball and socket joint, into the glenohumeral joint, you don't really need ultrasound because you've got bony landmarks that gets you in there with that problem.
Okay.
If you're doing something where you've got some calcification that or you have a small partial tear, where you want to make sure that you can accurately put your injection in, so in the subacromial space, so above your tendons, then ultrasound can be useful. So it can. So I wouldn't use it for every single one, but ultrasound can be useful for certain injections. Yeah.
So I mean, I've been fairly lucky throughout my life, not had too many problems with my shoulders, but I did have, and I think I spoke to you about it at the time. And I was just getting pain at the front of my shoulder and side. It wasn't really bothering me at night time, but at the gym, if I was to do an upright row, that shoulder was, I couldn't pull that up. I couldn't get that past that point, and now it's absolutely fine. And you got me to do a little test. You got me to put my arm out, turn my thumb down, and then you pressed on it and said, "Is that painful?" And it was a little bit painful. And I think you said it's probably a slap tear. So what is a slap tear? And why did it just get better by itself? Why did I not need an operation on it?
Yes, slap tears are, well, it stands for superior labrum anterior to posterior tear. And so if I show you my little model again, I'll take that tendon out there. So if you have a look here, so your biceps muscle has two tendons at the top end. Then there's a large one which is as thick as my finger that attaches onto this bit of bone called the coracoid in the front of your shoulder here. And there's a secondary tendon here called the long head of the biceps, which is this little skinny one there. It attaches to the top of the socket. So what a slap tear is essentially a little tear in the labrum that we spoke about, that little rim of tissue that runs around the socket, right at the top where the biceps tendon attaches onto the top of the socket, there. And there's different grades in terms of severity. And it's very common in throwers. So baseball players, for example, in America, it's very common. But I see it in cricketers. I see it in people who play lots of racket sports. And that is because they're constantly tugging on that tendon. So often you can get a slap tear if you've grabbed something heavy and it's fallen and it's sort of pulled the arms. It's a sort of traction injury. So you can see why throwing a lot or racket sports will cause a similar sort of problem. So you may well have had a little tear or have a little tear at the top because they don't often tend to heal on their own. But that doesn't mean to say that you have to have treatment for it, because there'll be lots of people out there who've got slap tears who probably don't have any symptoms, and sometimes they can be
the patient, not
exactly.
Not the injury as such.
So slap tears, but they can, in a lot of patients, become quite painful. I often repair them, depending on the symptoms.
So you just stitch them together?
Yeah, so you basically put a little anchor into the bone, and there's a little stitch there. So you freshen up the bone at the top where it's peeled off. You put some anchors in, and then you essentially stitch the labrum back down onto the top. So
an anchor's kind of a little device that has a stitch attached to it that you can then put into the bone and attach the soft tissue and tighten down, basically. Yeah,
there's lots of different types of anchors. We used to use metal ones. Now we've got some little special types of plastic ones, or now we have anchors that are made of sort of stitch material that form a little ball when you pull on them. And they're been shown to be as strong now as the original ones that we used. So they're much sort of less invasive. You don't have a big lump of metal work sort of shoved into your shoulder.
A bit softer on the soft tissue. So mine clearly got better. And obviously, I'm a fitness fanatic, so I do a lot of training. And it took me about a year, I think, to get over it. And I really did struggle with the upright row. Sometimes doing a bench press type movement, it was a little bit sore. I could feel one arm kind of dragging behind the other. And then, bang, a year later, it was absolutely fine. So I suppose, is that a mark? Is that how long it can take to get over these things as an average? Or?
It can do. You might have had a bit of impingement as well, where the rotator cuff tendon was getting pinched. And as you've sort of compensated and your other muscles have gotten stronger, then things have improved with time. Because your biceps tendon sits in front of one of your rotator cuffs, so your rotator cuff tendons come together and form a little sling here at the front. I don't know if you can see that there, where the biceps comes up. So your subscapularis tendon in the front here and your supraspinatus in the top, along with some other structures, form a sling for the biceps. So if you've got a problem with your rotator cuff, whether it's impingement or a little tear, that can have a knock-on effect to your biceps, because your biceps is then possibly free to slide around, or it can cause inflammation. So often patients who've got rotator cuff problems come and say, I've also got pain down my biceps. And the provocative test that we do for the biceps can be painful as well. So they often come hand in hand. It's not always one problem in the shoulder. It can be multiple problems.
Right. Okay. So I suppose falling on your shoulder, and especially things like skiing injuries. I mean, last year when I went skiing, somebody cut me up and I ended up going, head over heels, and I hit my shoulder. I thought, first I felt sick. I thought I'd broken my shoulder at first, but I hadn't. I was a little bit sore kind of over my acromioclavicular area, and I know when I came back, actually, I spoke to a friend of mine who goes to the gym, and he'd got this huge lump on the top, so he looked like he'd knocked his acromioclavicular joint out. And he didn't have anything done with it. He went and saw someone, I think, at Bassetlaw Hospital, and they advised him just to keep an eye on things, maybe do some exercise. He was struggling with press-ups, but now he can start to do that, but he's still got the lump there. I suppose my only experience of this joint really is when I was training, I spent some time with a generalist orthopaedic surgeon. He had an interest in foot and ankle surgery, but he was a generalist orthopaedic surgeon as well. And he did what I could only describe as a Keller's type procedure, where you cut the joint out an acromioclavicular decompression, he called it, and he basically just cut a space in there. So is that something that you still do? Is that, how do you deal with that? Do you just leave that alone, or when would you intervene with it?
So the different problems that you can have with the AC joint. So the AC joint, or the acromioclavicular joint, is this little joint on the top here, and it's where the end of your collarbone, the clavicle, meets the top of your shoulder blade, the acromion that we've spoken about already.
Yeah.
And a huge amount of force goes through that joint. Arthritis in that joint, even at a relatively early age, is really quite common, particularly if you do a lot of sports, particularly overhead sports.
There's not a lot of movement in it, though, I wouldn't think.
So there is. You'll be surprised. There's a reasonable amount of motion, particularly rotation. So your clavicle means little key because it rotates.
Right, okay.
It's a bit of classic education.
Yeah, there you
Tony. You'd be surprised that there is a bit of motion there. There's lots of ligaments around your AC joint to stabilise it, but it's actually quite an important joint because if you think about it, it forms the suspensory mechanism for your arm.
Right.
Because other than all of your muscles here, the only thing that really attaches the whole weight of your arm by the bones to your the rest of your skeleton is the collarbone.
Yeah.
So if you disrupt that joint, then you're relying on other ligaments that might still be intact, or the muscles to basically hold your arm on. So it can it can cause problems. So arthritis is very common, but a dislocation is a different thing. And instability following a dislocation in pain can be a problem, particularly for people who work overhead.
Right. So putting your arms up.
And there's like all these injuries, there's different grades of injury that you can dislocation that you can have, and some of which we recommend surgery for, and some often, other than the fact you've got a bit of a bump there, doesn't often cause a lot of problems. But you tailor the treatment to the individual, so some will fix and some we won't. But in terms of the arthritis, if you've got two bones rubbing against each other like that, then it will cause pain, particularly if you're reaching across your body or working overhead. And that can be quite painful. You're lying on that side at night, it can be painful as well. So there's an operation which, in fact, I did this morning, which is where you put a camera into the shoulder and you just shave off a little bit of bone between the two. It's only a few millimetres just to clear out.
So you're doing similar to what he did as an open procedure, but just on the key.
So we used to do it open. But now it's all done keyhole.
Right.
So and it's pretty quick actually in terms of the procedure, and patients are pretty quick to recover from it. There's no big scars. It's all done keyhole, and it does make a big difference to your pain, and it's a successful operation.
Right. Okay. So in terms of, normally when I'm dealing with an arthritic joint, there are only three things I can do. I can fuse it, I can replace it, or I can do what we're describing there, cut a bit of bone out and create a gap. So there's not really an option for fusion in this, is there? Because you want to maintain motion because of the way that the muscles are.
Yeah, not for the AC joint,
no. That's right.
But a fusion in the ball and socket joint is an option.
Right. Okay.
It's not one we do very often, but it is an option.
Is there any sort of joint liner that's coming on the market or can be done for these sort of joints, or is it always just going to shave some bone out?
That's the easiest thing. So there's a little tiny cartilage disc that sits in there normally. But with arthritis, it's often worn away. So when you look in there, there's nothing left other than to sort of bare bits of bone rubbing against each other, really. Yeah. So the obvious solution is just to remove, because you don't alter the ligament. The ligaments are still intact, and that's one of the big advantages of keyhole surgery, is that you're coming from underneath. You do not disrupt any of the important ligaments
so you're
around.
not cutting through them.
So coming from underneath, the ligaments are still intact.
Yeah.
So therefore, you can remove a little bit of bone to get rid of the pain, and it's pretty minimal in terms of the amount of disruption to the joint itself. Right. Whereas an open procedure, taking a saw to the end of it, you often have to take the ligament off and then repair the ligament at the end. Yeah. So things move on, don't they? And that's why we do a lot of stuff keyhole now.
Yeah. So is shoulder replacement a good option these days? Because I know the ankle joint took a long time to become a decent joint compared to the hip and knee, which has been around for many, many years. And I know sometimes you do a reverse shoulder, so you switch the joints around, probably because of the instability.
Yeah.
So what sort of things can you do shoulder replacement wise?
So shoulder replacement, I think, is a fantastic operation. We do a lot of them, and again, it's really taken off. Particularly the way we do things have changed substantially in the last sort of 10 years. Yes, hip replacements, and the modern hip replacements haven't been put in since the 60s. But I suppose you could look at it and say, well, actually, we have learned from all the mistakes that they made over 30 years before we started sort of doing it properly in the 90s. But there's two different types of shoulder replacement.
Yeah.
And my indications for shoulder replacement for patients, if they've got severe arthritis, is usually if they have pain at night time, they get pain at rest, or they're really struggling to do day-to-day things, whether that means washing, dressing, doing the hair, using cutlery. These are the important things.
Have they lost range of motion with the arthritis?
Yeah, so they often lose their range. So like any joint that becomes arthritic, it becomes painful and stiff, doesn't it?
Yeah.
Because you lose the cartilage, so you lose that sort of congruity in the joint. So shoulder replacement is a very common operation now. Yes, there are two different types of shoulder replacement. The normal anatomic shoulder replacement, which is where you replace the ball with the ball and the socket with the socket, relies on these muscles being intact. So your rotator cuff muscles that we spoke about, if you remember, I said that they're really important for holding the ball in the socket. If they are not doing their job properly, then I replace your shoulder with a new ball and a new socket, and they're not working properly or they're torn, then you're not going to be able to hold that ball in the socket. And that's either going to dislocate or it's going to slide around and cause eccentric load on the socket and cause it to loosen, and it will fail early. So it's really important that you know what the rotator cuff condition is like before you venture down the road of a shoulder replacement.
Is this atrophy of the muscles because of the lack of use over time and the pain that the patient's had? So I'm just thinking in my head that if you have arthritis, if you weren't an athlete like myself who's got good shoulders and you ended up with pain, then the muscles are going to atrophy away, so they're therefore going to become weaker. So isn't everybody's shoulder just weak, and you always need to do a reverse shoulder? How can you have good musculature?
Yes, so we're kind of getting into sort of finer details now, because you can have patients who don't have a very well-functioning cuff at all, but it's not torn.
Right.
But you've got lots of muscle atrophy, and the ball is sitting high in the socket. Because your rotator cuff is not holding it down.
Right.
It's a bit of a contentious issue.
It travels upwards.
It's a bit of a contentious issue as to whether we should be doing the standard shoulder replacement or whether we should be doing a reverse shoulder replacement for these patients. So a reverse shoulder replacement was designed by a Frenchman in the 90s, specifically for a condition called rotator cuff arthropathy.
Right.
So these are torn tendons, so rotator cuff tendons. So if you've got a chronically torn rotator cuff tendon and the ball is no longer held nice and centered on the socket, over time you can develop arthritis. And the other thing that happens, and we see it on the x-ray, is that the deltoid muscle, which is not on this model, wraps around the shoulder here. And it's the workhorse for your shoulder. It's the one that does all the work. So when your brain says to your hand, I want to lift it up, the deltoid is the one that does most of that work. And your rotator cuff muscle's job is to hold the ball centered in the socket so that your deltoid works and you have this pain-free, seamless motion in the shoulder. If you've got torn rotator cuff tendons and your deltoid is pulling, what it wants to do, because the way it wraps around the shoulder, it wants to lift the ball high in the socket. So the ball can sit up high in the socket, and this model won't move, but it doesn't have anywhere to go because it hits the underside of the acromion here, and it stops. And your deltoid muscle is then not held out to tension; it becomes lax.
It's almost like a dislocated shoulder. In effect.
Well, it's not completely out of the socket; it's a sort of subluxed, if you like, but it's sitting high in the socket.
Okay.
But because your deltoid is no longer held out to tension again, when your brain tells your hand to lift your hand up, you kind of get stuck about here because it's got to take up the slack first.
Right.
So that's what we call pseudo-paralysis. So you're not paralyzed, but it's a false paralysis, because and patients will often say, when I'm hanging my washing out or I'm getting a cup out of the cupboard in the kitchen, I have to use my other hand to lift my arm up to be able to use that hand, because I can't do it myself. So that's what we call rotator cuff arthropathy. So the reverse shoulder replacement was designed purely for that condition. And what it does is it medializes your center of rotation and it drops back down the humerus back into a position that will retension the deltoid.
It moves it towards the center of your body.
Yes, so if you take the center of rotation of the joint and move it towards the center, what you do is you give the deltoid muscle a longer lever arm to work, so it doesn't have to work as hard to lift your hand up.
Right.
So it's got lots of biomechanical advantages. Plus, the ball and socket joint that we create is more congruent than the ball on the flat socket that we for the anatomic type. So therefore, it's inherently more stable. So you don't rely on your rotator cuff for the stability of the shoulder.
Yeah.
And I would say now actually that the reverse type of shoulder replacement is probably the most common type of shoulder replacement we do in the world.
Right.
And the reason for that is that the vast majority of patients who have degenerate changes with bad arthritis in the shoulder also have torn tendons.
Right. Okay. So how do you know preoperatively that the tendons are torn? Do you use MRI scan, or is it just clinical examination, or is it just that you've got so much experience that you kind of know that this is likely to be the case?
Well, I've seen that many shoulders now that usually you can tell when you see the patient. But we do have ultrasound scan, which will show us the state of the rotator cuff.
Yeah.
MRI scan can be used. It depends on surgeon preferences to which one they prefer. But if you look at an X-ray and the humeral head is sitting high in the X-ray, then I can tell straight away that the rotator cuff is torn, and that we don't need to have any further investigations, because all that's going to do is just delay treatment for the patient.
I mean, I suppose a similar thing for me is plantar plate tear in the ball of the foot. You know, if the toe is sitting up, and you can tell that clinically, you do the Lachman's test, as we call it. I don't know if you have a similar name, where you just drag it up and down. You can feel it popping up and down. I suppose it's kind of a similar sort of joint in a way, that it's got a ball and quite a flat base to it, so you get that instability, and the predominant thing is pain and swelling. The toe then sitting up, and then it changes shape again because of the biomechanical imbalance to it.
Yeah, so you can often tell that, and the vast majority of shoulder replacements that I do now are reverses.
Yeah.
And things have moved on significantly. So we started doing reverses in the 90s, as I said, and it was almost used as a salvage procedure then. But now the design of it has changed significantly, and patients are functioning really well. I have a patient who's I've operated both of his shoulders. He's got an anatomic on one side and a reverse on the other.
Yeah.
And other than the slight change in shape of his shoulders, if you look at him, you can't tell which one's which, because they both function as well.
Right. Okay.
So they do. So traditionally, we're always told that anatomics function much better. You should do an anatomic if you can, and we would always try and do an anatomic replacement if we could. But the reverses now are sort of.
So you're kind of thinking in my head of putting the shoulder replacement in. So a ball, where a ball was before, you would think that you would have a stem on it, a bit like a hip, and it just goes down the humerus and it fits easy. But if you're putting a ball on the opposite side where there isn't a lot of bone to push it into, how do you fix it? Is it because it's a ball? Do you screw that on? Or
so we have a base plate that we screw on to
the.
So we ream onto the glenoid, the small socket, and they are small. Essentially, as I said before, it's like putting some screws in a base plate onto a golf tee, isn't it?
Yeah.
And it's a cone as well. So if you think about it, if you ream away any cartilage that's left or the bone, the more you ream away, you get an exponential loss of surface area, because it's a cone. So you've got to be very careful, and we often take away as little bone as possible. But some patients have got a lot of wear of the socket, so sometimes we have to build it up, either with a bone graft or with an augmented base plate, which uses metal to sort of build up the bone that's lost.
How do you fix a bone graft on, if you take a bone graft?
So we often will screw it on with the base plate.
Right. Oh, so you have a basically a packing between there, and the screw goes through the base plate and through the graft and holds the two things on. Is that
exactly?
But it's just to push it out really more than anything, isn't it?
Well, it's to try and reconstruct what's lost.
Right.
Because if everything's not out to tension, then you have a risk of either failure or instability. We have the advantage now of computer navigation for being able to do this. So the hip surgeons have the luxury of having a lot of bone, have a large socket and a large ball to play with. But I don't have that luxury as a shoulder surgeon. I've got a very small socket that I have to deal with, and you get one shot at it. So you have to get it right first time. So I use computer navigation for particularly the difficult cases. Not every case, but I do use it for a lot of cases now, which is a bit like sort of sat-nav for the shoulder.
So is that similar to the robotic hip and knee type thing, or is it a different thing altogether?
It's different, but it's similar in terms of accuracy, we think. So, so if the standard method of a shoulder replacement is that you use bony landmarks. So you can see what's in front of you, and you decide by eyeballing it the position that you want the implant to go in. Bearing in mind you get one go at it. And the advantage of the navigation is that you plan before exactly where you're going to put the implant, the size of the implant, the rotation, how many screws you're going to put in, where you're going to put the screws, how everything's going to line up. I do that on my computer. So we take the CT scan, which essentially is a series of X-rays that forms a 3D picture, and it gets uploaded onto my laptop, onto a special software. And from that, I get a 3D model of the shoulder, and I can then plan exactly where I'm going to put the shoulder placement, because the function of the shoulder placement does depend on the implant position and the accuracy of being able to put it there. So then what happens is that I plan the surgery on the app. And on the day of surgery, there's a tracker that goes on this bit of bone here on the shoulder blade called the coracoid. And it sits on there, and it's got some little markers in it. So there's a camera with a screen that picks up those. And I then mark some areas around the shoulder on the bone, and that allows the camera to know exactly where the shoulder blade is in space by matching it with the CT scan. And all of my instruments have trackers on them as well.
That's interesting.
So the camera knows where my instruments are in space, and it knows where the shoulder is in space. So I can, with a degree of accuracy of about 1 degree and 1 millimeter, implant the prosthesis from my original plan. And there's more and more evidence now showing that it does improve accuracy. It does improve the sort of increasing screw length to get a better hold within the bone. And there is now some evidence coming out to show that in the shoulder, because it wasn't, we didn't see that in the knee so much when it was used a number of years ago, but in the shoulder that it is starting to improve outcomes as well.
Right, okay. So do you see this as being the norm? Because I know when I spoke to Paul Haslam, knee surgeon, at one of our other podcasts, he kind of poo-pooed the robotic knee. It didn't really suggest that it almost looked like a marketing gimmick as opposed to something that was really revolutionising knee surgery. But the way you're speaking about this, it's almost like that is going to be the way forward, that people won't do it.
Yeah, and they're very different joints. The shoulder and the knee are very different joints. I don't want to shoot down the knee surgeons.
Sure.
But there are lots of studies looking at computer navigation in the knee, and they failed to show that it improved outcomes, really.
Right.
So there are still people who use it in the knee, but it didn't have they didn't get the results that they thought they were going to get from it. But the shoulder is a completely different joint. There are much more advantages for using it in the shoulder than in the hip and the knee, I think.
Right. So if someone broke the shoulder, then is that an indication for replacing it? Sometimes there are times when you damage it so much. Is it because the bone dies off? You get like kind of an avascular necrosis, as it's called, of the head.
Well, so shoulder replacement for fractures used to be for just the very bad ones where you couldn't reconstruct them. What we know now is that as you get older, your bone quality isn't as good, and fixation of fractures is much more likely to fail, particularly in elderly patients. And we find that proximal humeral fractures, so fractures around the ball of the ball and socket joint, are more common really in older patients, because the bone quality is not as good.
Is that because they've fallen direct? I mean, how easy is it?
So they fall. Yeah, so it's a bit like hip fractures. They're sort of fragility fractures, really. Having learned in the past, with having fixed these for years, many shoulder surgeons are now moving away from primary fixation for these fractures to just straight away doing a reverse shoulder replacement for them, because what we're finding now is that the outcomes are predictable. You can get patients going more quickly, and you don't have the problems with sort of metalwork cutting out, because what you don't want to do is have a 75-year-old with a very bad fracture dislocation of the shoulder that you have to do a wonderful job of piecing it all back together again. It looks fantastic on X-ray, and then 3 weeks later it falls apart because the bone quality is poor. So now what we do is we basically take the head out and replace it with a shoulder replacement. And you can do an anatomic or reverse.
Right, so you still have the choice.
The vast majority we use reverse for the elderly patients. What you don't want to have is an anatomic shoulder replacement that in a few years' time the rotator cuff fails, and then you end up with it having problems and having to be revised to reverse.
So these people have got fragile bones. Does a shoulder replacement still fix to the bone? Because if you talk about using a base plate and putting screws in there, is it still as strong, or still as good, or is there still risk? What happens if it if it becomes loose.
But there are a similar population of patients that we're doing the replacements in.
Right.
We have the advantage on the base plate that the screws are locking screws, so
Right.
they have a greater pull-out strength,
Yeah.
and you get
So when you say locking screw, the screw has a threaded head and it locks into the plate.
That's right. So it's locked onto the plate, the screw.
Okay, not just friction.
No, it's locked on.
Right.
There's a little cap you put on top of the screw that locks it
Okay.
onto the plate. And often, because you lose a lot of bone around the top, you're often having to cement in not always, but you're having to cement in the stem for the humeral side of the replacement as well.
Right.
You often will try, if you can, free up the tuberosities. That's these little bits of bone here where the tendons attach. So this is the lesser tuberosity, and that's the greater tuberosity here, where your rotator cuff tendons attach. So you want to try and see if you can preserve those with the rotator cuff tendons attached to them and bring them around the implant and attach them onto the top of the shaft where the fracture is. Because if they heal down onto the bone, then there is good evidence now that the patient's function is better.
Yeah. Okay.
And I've got patients who've had fractures who've got a fantastic range of motion and are pain-free, having had a replacement for a very bad fracture.
Oh, fantastic. So staying on the theme of kind of fitness, I know when I was working in trauma over the COVID period, I was helping out and I did a couple of bicep repairs with you.
Okay.
And a friend of mine, actually, I was talking to him, he was playing tennis and he suddenly ended up with this huge bruise around here and he was diagnosed with a bicep tendon tear, which I thought was a bit strange from a tennis, but he isn't overly fit, so it's maybe that he was just unaccustomed, did a bit too much and did some damage. So what happens with a bicep tear then? Because you talk about this Popeye muscle where the muscle retracts. Is it easy to tear your biceps? Is it that easy to do it? Can you do it with something like tennis?
You can. Well, it's not so common with tennis, but it depends on where you've torn it, because your biceps muscle has got two tendons at the top that we spoke about already, and one tendon at the bottom.
Yeah.
Or the two tendons form one tendon at the bottom. So if you tear the long-headed biceps, which we spoke about already, and lots of people tear the long-headed biceps who've got chronic rotator cuff tears.
Right. So there's a correlation between the two things.
Yeah, so if I see somebody who's got a Popeye sign from a long-headed biceps tear, so it's torn at the top and the muscles drop down the arm, then I always think about, is there an underlying problem within the shoulder that's caused this? Because it does happen. You can get biceps tendon tears on their own at the top end, but often they're associated with rotator cuff problems. But a biceps tendon at the bottom is a different problem, and that's usually caused by heavy lifting. So your classic is, I was moving the fridge, or I was lifting the sofa, or I was putting a fence post up, or whatever.
Yeah.
So fencing
it's
panel.
not necessarily do people do it by just doing dumbbell curls and things?
Yeah, so
like
you have
that?
to eccentrically load the biceps. So it's in a position where the biceps is loaded, and then what happens is the gust of wind comes and blows over the fence panel that you're holding, and it causes an eccentric loading, and it usually tears the tendon off the bone.
Right.
And
so it doesn't snap kind of in the middle then? It pulls off the bone rather than just splitting into...
It can tear in the middle, but that's not very common.
Right.
It can tear where the tendon meets the muscle, and that's also less common. The most common type is where it tears off the bone. I see it a lot in bodybuilders, particularly those who use steroids. So steroids are very good at getting big muscles, but it's not very tendon friendly. So you get big muscles and weak tendons, and unsurprisingly, they have a high rate of rupture of the biceps
it's
tendon.
An imbalance again, isn't it? Really?
And whether you fix them or not is dependent on the individual. Because although the procedure doesn't take particularly long, it's your biceps tendon is sitting in amongst all the major clockwork in the front of your elbow. So it's tiger country there, and you've got all your major nerves and blood vessels that supply into your forearm and into your hand, all in the front of the elbow next to where your tendon is. So it's not without risk. But we have that discussion with patients in the clinic to see, would you be somebody who would benefit from a repair, or would you be a patient who would probably be better without? And there's lots of reasons for wanting to have surgery versus not wanting to have surgery.
Function-wise, I mean, if you didn't have a surgery, do you miss it? I mean, can you still do exercise? Can you still do bicep curls and things like that?
So, yes. So the misconception is that your biceps is a main flexor of your elbow, of your forearm. But actually, the main flexor of your elbow is the brachialis muscle, which sits underneath the biceps.
Right.
The biceps muscle is actually really important for that movement there, and that's called supination. So bringing your palm up towards the ceiling. So if your biceps tendon tears and your biceps pings up your arm and it's left and it scars down in that position, it will scar down onto the brachialis muscle. Right. So you will lose a bit of flexion strength, but not a huge amount. The literature would state about 20% of flexion strength you would lose. Wow. So depending on what job you do, if you've got an office-based job or and depending on how old you are, then that might not affect you day to day. But what it will affect you is your supination strength. And so if you are somebody who is an electrician or a joiner and you're using screwdrivers all the time, or a mechanic who uses socket sets, and you're relying on that motion daily, then you are somebody who would benefit from a repair, because you can, according to some of the studies that have been done, lose up to about 50% of your supination strength.
Right.
In which case, if you're somebody who's young, who has a job that requires supination, then you'd be more likely to benefit from an operation. Having an operation is all about weighing up the risks and benefits, course, as you know. Yeah. So there's no right or wrong answer. Some patients will say, yes, I want it. Some patients will say, under no circumstances am I ever having an operation. Yeah. So it's just about weighing up the risks and benefits. And for those patients, they might say, it's worth taking the risk of possibly a nerve injury or some numbness on the side of my arm, because I know that I would benefit if I have it repaired.
Right, okay. So just moving a little bit further down then, there's a couple of things I just want to ask you about, because the names golfer's elbow and tennis elbow, they're not the same thing. One's on one side, one's on the other, I take it. What are they all about? What are people, what sort of problems? You see people with these little things, little pads on their arm, and I often think, is that actually doing anything? What is that? What is that doing?
So golfers and tennis elbow are almost sort of misnomers, really. So tennis elbow is the common one that we see a lot of. I've had tennis elbow myself. Many of my colleagues have had tennis elbow. It was sort of traditionally called tennis elbow because it was associated with the backhand in tennis.
Right.
So basically what happens is that all of the muscles in the back of your forearm, which lift up your wrist and your fingers, all form one common tendon called the common extensor tendon, which attaches onto that bobbly bit on the outside of your elbow, which is called the lateral epicondyle. You get little tiny micro tears within that tendon. And then it causes sort of little new blood vessels to come in. And the problem with tendons generally is that, as you probably know yourself with the tendon Achilles, is that the blood supply to tendons in our body is not great. It's a bit of a design fault, really. So for that reason, they don't always heal. So if you've got some little tears, or sometimes even a reasonable sized tear, sometimes they won't heal and you get this chronic problem where it goes on for months and months, sometimes even over a year or two. The vast majority will settle down within a year. Mine settled down within 6 months, and it wasn't too bad. But I do have patients who come and say to me, look, I can't do my job, I can't sleep at night, I can't grip anything, I can't even lift the kettle up because the pain's too bad. And this has been going on for 9 months now. What are you going to do about it? So that's your tennis elbow. So I don't often see it in tennis players, but I do see it in people particularly who have manual jobs. So the classic is, I was renovating the house and I knocked the kitchen out, and now I've got tennis elbow. And it's not settling down. Golfer's elbow is the same pathology, but on the other side of your elbow. So that's your flexor tendons. So they all come together and form the common flexor origin, which attaches on that bubbly bit on the inside of your elbow called the medial epicondyle. So it's a similar pathology, but tennis elbow, I would say, is more common. So when I see patients, the classic is they say, I want a steroid injection. And traditionally, patients were given steroid injections. And they'd have a steroid injection and they'd go off and you'd never see them again because it must have worked. How many of those just got better on their own, we don't know. As time has gone on, we now realise that steroid is not particularly tendon friendly. So go back to sort of bodybuilders that we spoke about. And although steroid gives pretty quick acting pain relief in the short term, there is now evidence that suggests that after about a year, about 1 in 5 patients can actually have worse pain after steroid injection. And I'll see patients who've had 5, 6, 7 steroid injections that the GP's given them, and that it's not great for your tendon having all that steroid around it. Plus, it also causes problems with what we call fat necrosis, which is where the sort of fat dissolves over the top and it becomes very prominent and bony, that bit of bone, and patients bang it and knock it, and it's painful. So we are, although there's still a place for steroid injections, we're kind of moving away from it now. There's a new treatment which you know about, we both use, called PRP, so platelet-rich plasma injections, which is starting to gather momentum now. It's been I've been using it in the NHS for about sort of 4 years now, and it has good results in my hands. We've audited it, and I would say that in my hands it works about 80% of the time.
And what is it physically doing?
Yeah, so basically PRP is where we take a blood sample from the patient, usually it's about 30 mils of blood, and we spin it in a machine, a centrifuge. And what it does is it spins out the cells in this specially designed tube into different layers. Yeah. And the layer that we want is the one that's got the platelets, the growth factors, and the white cells. Yeah. And those are the cells that in your body that your body normally uses to heal tissues. Things, But the problem is, because the blood supply to a tendon is relatively poor, your body almost sort of gives up trying to heal that tendon. So what we're doing is we're taking those cells and we're injecting them directly into where the problem is, and in the hope of kickstarting the healing process. Yeah. Okay. And certainly, I would say that the majority of the time they do work very well, actually. There is some anecdotal evidence, I would say, in my own practice, that if there's a sizable tear, I don't think PRP works as well. Right. But if there's no tear, and that's something we're probably going to look at in a study in the near future, but if there isn't a tear, then they do seem to work well, the PRP injections. Okay.
Because I kind of look at the golfer's elbow and tennis elbow as the heel pain of the elbow, really, that plantar fasciitis.
It's the same pathology, isn't it?
Yeah, plantar fasciitis and plantar whatever-itis that patients struggle to pronounce. But it's always one of those conditions where you think, oh, I'm so sick of that heel pain speech, because it's, we tend to work on a triangle of trying to support it. So I suppose that's where the little splint comes in on your elbow, trying to reduce any inflammation, although the evidence really is that there's not a lot of inflammation with plantar fasciitis, hence we've started to call it plantar fasciopathy, so it's more of a degenerative change. And then exercises to stretch out the muscles and tendons around them. And once you've got those base layers in there, some people will get better, other people won't, and then we move on to things. And again, I would agree, certainly steroid injections, there's very little evidence in the plantar fascia for steroid injections, although we still use it, but we tend to use a technique called needling. So we basically stabbed the fascia under ultrasound multiple times, which, what does it do? It maybe stimulates it to try and help it to heal itself. I mean, it kind of seems a little bit back to front that you're actually injuring something that doesn't heal very well because it's got a poor blood supply, to get it to heal a little bit. Do you do a similar thing in tennis elbow? Do you stimulate it with a needle?
Yeah, so if I do a PRP injection, then I'll do some needling at the time, and we don't know whether it's the needling that makes the difference. Is the fact that you are creating some trauma and bleeding, is that what's kickstarting the healing process rather than the PRP injection itself? We don't know that, and that's certainly something that we'll probably know in time when more studies come out. I think it's important to say that with all these things, though, and most of the pathologies that we see, steroid injections, PRP injections, or even surgery, they're not your sort of first go-to treatment. So we'll always try a tennis elbow brace first, and physiotherapy for eccentric exercises, to try and see if we can improve it without the need for invasive procedures. And a lot of patients will improve with just a brace and some physio. But for those that don't, we do have these options. Right. And your last option, surgery, which I have to say I don't do much of now. Maybe I'll only do it a few times a year. And I think that's probably
because of poor results.
I think it's because the PRP seems to be reducing down the number of procedures that I'm having to do. So, and that's just where you make a little incision over the tendon, and you take out the area of the tendon that's affected, and then you can either put a little anchor into the bone to heal it if it's a big tear, or some people just close up just the tendon and the tissue over the top. And again, that kickstarts the healing process and allows it to heal back onto the bone again.
Is it an operation that you feel confident with going? I know for plantar fascial problems, I mean, I've got two options from a surgical point of view. One is to just cut the plantar fascia, the medial band of the plantar fascia, and release it. The second is to cut the gastroc, the outer muscle on the calf, and allow more movement, because there's an evidence that lack of movement to the ankle joint is associated with heel pain. I always feel even more uncomfortable about that, because it's like your heel's sore, but I'm going to cut you at the back of your leg, and you know it's one of these operations. Both of them is where I'll do it as an absolute last resort, but I never feel confident that it's going to work. Not like correcting a bunion where you think, you know, I know it's going to have a predictable outcome. This is very much unpredictable. Is the surgery for this similar? Well,
there's different techniques, and so some surgeons will make a small incision and nibble off a bit of tendon, and that's it done.
Right.
Some surgeons will go to the extent of sort of taking it off, freshening up the bone underneath, doing a bit of a lengthening of the tendon to try and take some of the tension out, and then re-repair it again. So there's a vast spectrum of what, but the majority of people will just do a sort of tenosyllable release, where you go in and take out the area that is diseased, and then repair it.
Right.
But there are lots of different techniques with everything, isn't there?
Yeah. Well, thanks very much, Scott. That was a fascinating journey into shoulder and elbow. So if someone wanted to get in touch with you, then what's the best route for them to take?
Well, the best way to get hold of us is through Coriel Orthopedic Group.
Yeah.
So you can either get hold of me on the website. I'm on Doctify, so that gives you contact details as well. But Coriel Orthopedic Group's the way to get hold of me.
And you do work at the Coriel Clinic, High Street Hospital?
I do work at the Coriel Clinic, yes.
Yeah.
As well as Park Hill Hospital, privately.
Fantastic.
And my NHS practice is at Doncaster and Bassetlaw.
All right. Thanks very much.
Okay. Thanks.